So I want to recognize that it's the end of a long day and there's a point of saturation. And so thanks for sticking around. I appreciate this opportunity. I have a very kind of lovely and hopeful topic today, but I want to just speak to, I think, my appreciation for the gentleman that just presented prior. It's sobering, the situation that as providers that we are facing with addiction. It's insidious, and addiction itself has always been incredibly creative, manipulative, persistent, and now it just feels, to what the agent said, overwhelming, right? And so in my line of work, I'm a psychologist. I work at the VA in Salt Lake City. I'm at the main hospital. I am the acting program manager of a residential rehabilitation treatment program. And I have the privilege of working with veterans that struggle with addiction. And so when I think of what was shared all throughout today, I think of how important and critical it is when we do have our veterans come into the treatment setting. We got a little window because now, more than ever, it's even more clear what awaits them out there. And to their point from before, I'm losing patients right and left. We have almost a 4-month wait list, and so we have to call veterans every week that are on the wait list to see how they're doing. And it is not uncommon at all for folks that we know well, and folks that have used drugs for most of their life, that understand how to use their substance of choice generally. They can manage it, and they're dying now. So what I was sitting with, and I appreciated the mindfulness exercise so much, was just truly, when we have this window, how do we optimize it? So with that, one of the, here I'll start. I'm going to be speaking about the benefits of equine-assisted therapy for veterans in a residential substance use disorder treatment setting. To what I already described, so SARRTP, this is the residential rehabilitation program. We are housed at the VA Medical Center. We are in the building right above the inpatient psychiatric unit. We have a 15-bed currently program. We are expanding it to 30 beds as soon as we can get staffed. And even then, like I said, our wait list is up to 4 months. So it's a little snapshot of how pervasive addiction is in the moment. Our primary goal is to really address addiction, but not just addiction, the impact that it has on every part of life. So if you're in the field, you know that addiction doesn't operate in a vacuum, right? When our patients come into us, they are struggling in pretty much every domain of life. When you're in active addiction, you're not sleeping well, you're not eating well, your relationships struggle, your finances are in trouble, employment is often either not a thing or it's in jeopardy. Right? Can anyone think of one part of life that addiction doesn't touch? No. So when we have people that come in, our philosophy, what we offer is a very biopsychosocial approach. It's very much tailored to the patient, to the veteran, where they're at and where their goals are. It's a voluntary program. However, there are a lot of folks that are court mandated or they've gotten in trouble, so they're trying to maybe get ahead of the charges. People come to us through many different routes. So they could have come through the emergency department. They could be brought in by police. They could be coming from a setting of incarceration. They could be coming from the inpatient psychiatric unit. Oftentimes the hospital, they've required medically supported detox, or just coming from the community. So we've got paths from all different parts of the system. Part of what we offer, we deal with housing, OT, PT. Well, I'll get to that in a second. So that's the setting that we had pre-COVID. this kind of speaks to, this is kind of the VA decision tree, so to speak, of how someone comes in. We do assessments. If you guys are familiar with the ASAM criteria, that's generally what teases out who meets residential criteria and who can maybe do outpatient and IOP or a community provider. But essentially, to come into the program, you need a substance use disorder. But how often is it just an SUD diagnosis? Rarely, right? What we're treating and what we're actually really treating is the root, the etiology of the addiction, right? It's very rare that someone says, I still love my drug. It still serves me well. It's still a great distraction. It still helps me get through my day, right? They've passed that point. Now we're sitting with depression, anxiety disorders, mood disorders, psychiatric disorders. I can't tell you how many patients over the years come in, maybe they start with an alcohol use disorder, and they come in and they're, relatively functioning. They may have gotten in trouble, maybe their partner's gonna leave them. They go out, continue to use, come back a few years later, and now let's say it's a stimulant use disorder as well. And now in the context of stimulant use, they present with psychosis. Come back again another few years, and that psychosis is now fixed. Those delusions are now fixed delusions. So addiction is evolving, it's complex, and it touches all parts of life. So in addition, we have chronic sleep issues, chronic pain issues, personality disorders, and we're also a dual diagnosis addictions and PTSD treatment. So we also treat both military-related trauma and also non-military related trauma. There is so much trauma that goes along with addiction. There's so much trauma that comes along with homelessness, so much trauma that comes along with dealing. A lot of our patients are involved in prostitution, human trafficking, anything to keep and gain access to their substance of choice. So that's who shows up. Here's just a quick snapshot of our population, the years in which we did the research. So it's kind of what you think when you think of the veteran population, even specific to Utah. So mostly white, male, 12% female, 2% transgender, Hispanic representation, Native American, African American. Average range in those years were 45, the youngest 26. We have someone currently who's 20. Oldest for those 2 years was 73. So you can see with not only the variety of use, we'll get to that next. This is what we treat. We treat everything. And what we're also finding is that polysubstance abuse is a more and more common presentation. And polysubstance abuse doesn't just mean I like more than one drug. It's I'm actively using 2 or more drugs and I have an equal, I need them equally, right? And so sometimes it's kind of the self-medication, right? I drink because I need to do this, I use stimulants to get high, then I use opiates to calm myself down, or I'm using benzos, or I'm using this for pain. And so, our veterans are often their own kind of walking pharmacy and pharmacist. We also do a lot of comorbid addictive behaviors, so that can include eating, gambling, pornography, all the other kind of addictive behaviors that overlap. But in terms of addiction, right now, and it was interesting, I noticed the other day as a team we were talking, and someone said, at least they're just using heroin. And it really just hit me, right? The thing that used to, make us all gasp, now is the thing that at least it's not fentanyl, at least it's not carfentanil, right? So again, oftentimes folks come into treatment early, or they're maybe their first time with one addiction, but as addictive behaviors persist, and mood disorders persist and anxiety and trauma persist and they're not treated, they come back with new addictions, because addiction, again, it's evolving, right? So knowing that it's a complex group with a wide variety of ages that we treat. Now, how do we treat addiction? Pretty much across the board. Anything that's empirically evidence-based, we offer. So relapse prevention, CBT for SUD, MET, motivational enhancement, motivational interviewing, smart recovery. I'm so grateful for any kind of either 12-step or SMART, any program that's out there in the world that's free, that's accessible, that provides a community, has become more and more valuable in the recovery process. Mindfulness-based relapse prevention, ACT, is a huge part. Trauma-focused interventions. Now, pre-COVID, I want you to kind of look on the recovery model side of it. Pre-COVID, this is really what we're offering. We have some really cool post-COVID things that we're doing in terms of MAT. So we do have needle exchange programs, fentanyl, strips. We're also doing MAUD and MAUD. So we're offering harm reduction as well. But the problem is, and then for trauma, we do prolonged exposure, CPT, EMDR, written exposure therapy, and STARE. So again, all of the evidence-based, and because we try to individually treat both the patient, the trauma, and the addiction and their circumstances, that helps us determine what type of intervention. So then COVID hits, and most of the things on the right-hand side became compromised. We became a locked unit. Folks couldn't leave. Family integration, which is a huge part, right? Systems is a huge part of addiction. A support system is paramount. And a compromised support system is one of the reasons why people got to this place. They lost access to so many fundamental parts of our treatment program. One of those was our rec therapy program. Currently, when we're a little bit out of it, or at least a little bit more open, that we had integrated at least 2 days, 2 afternoons for rec therapy, and that was a huge part. And why, just off the top of your head, why do you think that's an important part of recovery, to integrate rec therapy? Yeah.
Rec therapy provides the opportunity to connect with people in a social setting and get outside.
Absolutely.
It increases our mental health.
Totally. So you have the physical benefits, moving, communication, connection with people. Perfect. What else do you think rec does for us? Yeah, right? So much of addiction and mental health is this belief that we can no longer do things, right? It's a belief in hopelessness. It's a belief that we don't have the capacity to tolerate pain or negative emotion, right? I can't tolerate this, so I'm going to use this because I have no other alternative. And what rec offers us and our patients, and it's extraordinary, is the ability to realize they have more capacity, the ability to feel joy, to do something they didn't think they could do, right? Climb a wall, work with horses, do bike rides, go skiing, and we have all versions of adaptive interventions. And they lost that. We were doing paper airplanes in the hallway and doing scavenger hunts around the VA just to get people moving. But the outcome was that people were bummed. People were leaving the program. Missing that element and all the things that were part of it was negatively impacting. So we had a very blessed, and I don't even actually know how it came across our path, but what happened was that we got access to a grant, the Adaptive Sports Grant. And I think because the other folks weren't able to use it, we got access to that. We got clearance to then partner with Utah State. And I cannot say enough with the amount of humility and gratitude that I have for the USU staff. And one thing that kind of I noticed as I was putting this together was that, yes, I'm going to tell you all the benefits of the program for our veterans, but I'm going to also say there was incredible benefits for the staff that got to be part of this. Not only learning a new skill, but man, we needed that too, right? The acuity of our population, it's heavy work. For all of us that are in it, it is heavy work, it's scary. And COVID made it that much more scary, right? So what are some of the key things that overlap between addiction and trauma? Avoidance, depression, anxiety. So already baseline, right? You've got very sick folks. Now, COVID reinforces isolation, avoidance, loneliness, hopelessness, right? So already once high acuity population, now they're in critical states. Also, we have housing limitations, legal things have slowed down. All these other things that allowed people to move on with their life and heal have now slowed down significantly. So here we have this opportunity and we take it, and it's extraordinary. And we start going out every 2 weeks and doing a 3 to 4 hour intervention. We are guided by IGALA, and the activities are path driven, and the actual, it was like, I think 5 or 6, is that right, McKenna? The pathways to horsemanship? 5. So that's McKenna Osborne, and I'm just gonna say, like, she walked me through every step of the way, my staff and myself. It was a very cool partnership that happens in an equine-based intervention. So you have the mental health component, and then you have the equine component. And both are equally important, right? We're both looking for different types of safety. We're both aware of different dynamics that are happening in the arena. And we're both looking to each other to set the flow and direct the intervention to be the most impactful. And so without McKenna and the whole team, man, we would not have had the outcomes or the experience that we got to have. So for that, thank you. Here's what showed up with our patients. Compromised self-esteem. Very, very, very deteriorated trust, both in self and others. And I'm gonna say that is across the board with addiction. Addiction, one of the first things that it does is it pushes people's moral compass. The thing that they said that, folks, I will never do this, I'll never shoot up, I'll never sell myself for a drug, I will never steal from a family member, I'll never drink and drive, right? All those things that we said as this line, this definitive line of this is who I am, these are what my values are. Give it time and addiction will push past that. And once that happens, trust in self and other gets deteriorated rapidly. So that's another that's another presentation that showed up with us in the arena at USU. Poor self-esteem, here I am, I'm in treatment, I'm homeless, I have legal issues, my family doesn't talk to me, right? All those negative self-talk and that is compromised. And then you look at the heart of addiction and impulse control, right? Addiction and trauma present with compromised impulse control. And so again, you step into the arena with these large animals, right? And you present with impulsive behavior, you're gonna get an immediate feedback loop about who you are, how you show up, and the impact of your environment. So one of the things that we started relying on for the EAL and the EAP interventions were how do we rebuild a working alliance with our veterans? The main domains that we really struggled with in our current treatment setting were trust, safety, and transference, right? So as providers, especially in that window, there was just, we all went through it together, right? And for those of us that were working in hospitals, it was a complicated time across the board. And so what we showed up, our fatigue, our own beliefs, our own frustrations were all there and presenting, I think, significantly. So we started relying on this intervention to help maybe address some of these things. So we looked at barriers to treatment and ways that our veterans were getting stuck in their addiction and in their recovery. Avoidance is another huge one. Like I said, it's the overlap, it's the glue that sticks addiction and trauma together, right? And then also stages of change. Because people come in from such different places, different backgrounds, different reasons for being there, most of them are at a different place of change. And so how do we have a milieu, an interpersonal setting, a peer recovery group, a support group that's all at different places? And what we started to find was that the horses kind of cut through the experience, just equalized a lot of these things that we were struggling to treat in the context. So qualitatively, what we started to observe and what we started to notice that we knew it was working was what they experienced was non-judgmental interactions, right? And when you don't feel judged, you can start doing some really beautiful work. We can start addressing the way trust in self and other has deteriorated and start building confidence and resiliency. When you have the space to make a mistake, when there's an invitation to not do something perfectly, it's an invitation for growth. And that's what we started to see. And the horses could give that to our veterans in a way that we couldn't. We also started to integrate mindfulness and distress tolerance. We started to use all those skills that we practice in groups, but put them in what could be and what was for some a stressful environment. And it was stressful because, one, for some people it was a new environment. It was stressful because here I'm out in the world again, I'm in a new place. Stressful because we're in a group. Some people didn't want to be there, some people really wanted to be there. Some people had relationships with horses in the past that was negative, or that they just thought of the equine or horses in general as a working animal. What am I doing why is it in therapy? It's just a working animal, right? And what we found was that because it's a projective and narrative intervention, that we would see people, all the things that they were thinking and feeling, they would start saying, but it would be in terms of the horse, right? So McKenna and I would stand on, the side with the group, and we'd watch the horses for a while and we'd say, oh, what are you noticing? And you'd hear comments like, oh, they're super, like they don't want to be here, they don't like us, right? Or we would do an activity and they'd say, oh, they hate me, or they're scared of me, right? And so that would be my job, is to kind of sit and ask, well, where do you see scared, right? Where do you experiencing the horses hating you, right? Well, I don't know, look at, they're turning their back on me, or they're not looking at me, their eyes are down, or, right, and they would project these horse behaviors. And the beautiful partnership and tandem with the equine specialist, then I could look at McKenna and she could say, well, can I tell you a little bit about horse behavior? And when a horse is relaxed, you can see the head is down, or look at the back legs, it's bent, right? She would demonstrate how the horse behaviors actually were demonstrating something very different, right? Because prey animals, they don't have the luxury of being polite, do they, right? A horse it's not gonna look out for your feelings to try to make sure everyone feels okay. It's wired to protect itself. And so if it is observing high anxiety, if it is observing erratic behavior, right? If it is tapped into your elevated heart rate, it will in fact respond accordingly. But when you have an ES as your partner, they can say, yes, this is what's happening. This is what the horse behavior is indicating. So it removed the human. It's not, just, their therapist saying, yeah, the horse really likes you. It's like, no, actually the fact that it went to the bathroom, right, said that it was comfortable enough to do that, right? Its head is down because it's relaxed. Or this is what we know about this horse, because a lot of the program has horses that are also in some form of rehabilitation or trauma recovery. And so we were able to use the horse's history and share with that somewhere in the intervention. And it was so beautiful to watch people relate to the horses, right? There's a horse that has a very significant scar going down its back. And it started to really, I think, represent a lot of trauma and war wounds and emotional wounds that our veterans came with. And as it progressively became more comfortable with the group over the weeks, our veterans would then use that as a very symbolic projection of their own experience as well. There's something about dogs and horses that gives us permission to be loving, to let our guard down, to be affectionate, right? And so we watched people start identifying their feelings and emotions and saying, wow, I feel really sad, right? Or this, I feel really hopeful, and this felt really good. And we'd ask, like, when's the last time you felt really good like this, or really connected? And a lot of times they wouldn't remember. They would have no recollection of a time where they felt connected to another living thing or felt really good. Or that they would say, God, that just flew by, right? Prior to the session, they'd be like, oh, I can't do this. And then we'd be done, and they would say, oh my God, that was so fast. They had this presence and mindfulness that they couldn't experience in another environment. They started also generalizing to other parts of the treatment. So we would have these interventions, we'd have these 4-hour sessions, and we'd observe. And sometimes, the magic didn't happen in the moment, but as the week went on, the group would then reflect back and say, I remember when you did that, right? Dude, you walked away and you weren't part of that activity, or I noticed you were so scared, but you did it, you stuck with it. It became integrated and generalized throughout our whole treatment stay, and it continued to get reinforced as we came back time and again. I'll give you a case example, one that stands out to me. 56-year-old, white, cisgender male, very complex biopsychosocially, stimulant use disorder and alcohol use disorder as a result of such long and heavy use, presenting with cognitive deficits related to Wernicke's aphasia, homeless, significant pain, also legal issues. Because he was on the lifetime sex offender registry, it impacted where he lived, where he could work. It impacted his relationships and the ability to make new relationships. He was one that did not want to be part of the exercise, did not want to partake. And when we had groups that maybe had less experience with the horses or were a little bit more timid to go into a big open space like the arena, oftentimes we'd follow McKenna's guidance and we'd start out with grooming. And grooming is such a primal, beautiful, intimate action. And what we started to see with him, here's someone that hasn't had intimate relationship or connection, and then you add COVID onto it, struggled with employment, had no community, no support system. And this invitation to connect physically with another human being in the process of grooming. And he would lay it's emotional because he was so rigid and so protected because of how he saw himself of worthlessness. I am unlovable was one of his core beliefs. I am worthless, I am unlovable, and this is all I'll ever be. And for this small window of time, he felt lovable because the horse will not BS you. And when the horse leans in and accepts that connection, that intimacy, that grooming, right? We watched how not only he experienced the connection, but how he started to internalize it and reassess his self-worth. And it was beautiful and it was extraordinary. So that's just one small example of the complexity of addiction, of legal, all the pieces, but put in the context of an equine intervention, it neutralized so many of those things that were stuck in them and also barriers to getting better. Okay, I will go through this very, very quickly. So once we saw the qualitative pieces, then we decided we wanted to quantify it. And we did 2 studies, and I'll just combine them together to optimize time. And so the first one was 33 participants, and the second one we did was, I want to say 70-something participants. 94 participants. The demographics, what you would think, 87 male, 7 female. And the difference between the two, the first one we looked at just one single session. We looked at pre and post. So we used these 3 validated instruments. We used the STAY 16, the craving experience, and the PANIS. And so we looked at trait state, anxiety, right? Trait being, this is my baseline, state being, this is how I feel when exposed to something that I identify as stressful. And we looked at craving before and after, right? So what are my cravings when I come prior to being in the arena, and what are my cravings after my 4-hour session? And then PANIS is the positive and negative affect. How did I feel? Were my positive feelings high or my negative feelings high? The outcome of the single session was across the board, the PANIS, the STAY, and the CEQ, they were all improvements. And they were significant improvements. And we saw that what we saw was that cravings went down, anxiety went down, and mood went up. So then we wanted to see what if, well, one other thing that's actually important, especially for our population, is that we have a high suicidal attempt and ideation rate in our population. And one of the powerful things that we found is that veterans that had either had an attempt or thoughts with a plan within 30 or 90 days, their mood significantly went up the highest and their negative affect went down the most. And so when you think about actually what that means outside of all the numbers and the statistics, it means they started to feel hopeful and they started to feel worth. And if you can be hopeful, you can work through a suicidal thought. So that was probably, for me, the most significant finding of the intervention and the outcome. Next thing what we did was we broadened it, and we also found that it was safe, it was replicable, and that it was feasible, that it was a feasible intervention. Now we added 3 to 4 sessions to see if more was better. And the outcome of that, before I pass it over to Dr. Hoops, was that we found that probably 2 to 3 has the strongest outcome. After the 3rd and 4th, it seemed to level out a bit, but we still had the negative shifts, reduced cravings, improved mood, reduced negative affect. Yeah, that's it in a nutshell. So really beautiful experience, a beautiful partnership, and really grateful to be part of it for ourselves and for our veterans.
Let's see if I can bring this up. Maybe. Here we go. Let's see if it comes up.
Now that it's time.
Now that it needs to happen.
I'm gonna close this one, right?
Yeah.
Because maybe it's not opening.
While she's pulling it up, I'll introduce myself. I'm Karl Hoops. I'm a veterinarian. And as Heather mentioned, this all started right in the middle of COVID. And I received a seed grant from USU Extension. And Judy Smith and I went down to the VA and met with Dr. Marchand. And together we formed this this partnership. And Judy Smith and myself, we had a few different programs that we were doing, and it was just wonderful. It was exciting. There we go. Great. Thank you. So it started in the middle of COVID, and we were very fortunate. USU had a lot of different rules and regulations surrounding COVID. But because of the VA and the partnership that we had with them, we were able to start our programs back up. And it was very, very important to us to get that back up and running. And so we had a lot of good programs, and we were very excited about it. I am a veterinarian. I graduated in 2003, and I practiced for 12 years in 15 years in Cache Valley. And it's amazing to me that I'm here before you today presenting something that I feel pretty passionate about. In 2015, I became the equine extension specialist, and we started programs where we would take military personnel, veterans, on trail rides. We call it Ride Utah. And it was all based on, well, I misspelled Winston Churchill, didn't I? Wow. But Winston Churchill made a quote. He said, "There's something about the outside of a horse that's good for the inside of a man," and I truly believe that. I believe that we become better when we associate with horses. And so there are a lot of programs out there of equine therapy. We hear this term equine therapy, and it encompasses all of this. And so there's just a few terms that I thought I would bring up. We have equine-assisted services, and on one side you have equine-assisted therapy that encompasses a professional, either a mental health professional or a medical professional that is trying to accomplish something with that horse and a patient. On the other side, we have equine-assisted activities, and these range from, they vary from adaptive and therapeutic riding, recreational riding, or equine-assisted learning, EALs is what those terms are called. And those are necessarily oversaw by a mental health or a medical professional. On the other side, we have those that are oversaw by a mental health and medical professional. You have equine-assisted mental health, and in that you have equine-assisted counseling, equine-assisted psychotherapy, and then another whole section called hippotherapy, and that's where you get your occupational therapy, physical therapy, and speech and language therapy. So there's a lot of terminology there, a lot of different areas. So if you're going to put on an equine event or an equine-assisted service, how do you do it safely? First of all, you've got to have the right personnel and training. You've got to have, and you have to operate within your role in that situation. You've got to have an equine specialist, somebody that knows the horses, recognizes equine behavior, and is able to keep everybody safe in the arena. You have to have your mental health professionals or your medical professionals, sometimes both. When we would do our trail rides with the VA, we would have both a medical professional and a mental health professional on the rides with us. Other parts of my rides, we don't always have the mental health professional and that, or the medical professional, and those are on the recreational side of things. Another key to success is you've got to have the right horses. You've got to be able to know your horses, know behavior, and as you choose the right horse for temperament, experience, and conditioning, as you do that, you can have safe equine-assisted services. You can do it. It can be a wonderful experience. And also you have to follow your protocols. That's so important. Safety is the key with these horses. You outline your safety and you don't vary from that. You make sure that the horses you're using have been evaluated and you trust them. You make sure that the trails you're on or the conditions that you're in, the environment you're in, are as safe as you can make them. Now we understand horses are still horses and accidents can occur. But as you follow your protocols and as you follow your safety protocols, you can do safe activities. There are a few programs out there that help certifications. There's the American Hippotherapy Association, PATH International, EGALA, and Certified Horsemanship Association. And I don't claim that you have to be certified to be able to put on these things, but you have to be able to demonstrate your ability to work safely with the horses. Now these are the equine specialists, and we do not try to cross over. We do not try to become the therapists. We're there for the horses, and that's what I am. I am one of the equine specialists. As a veterinarian and as an equine professional, I've worked with horses my whole life, and it takes that. And just real quickly, I'll go through a few slides with Ride Utah. Ride Utah is an event where we take military personnel on trail rides around the entire state. It is beautiful, it is wonderful, and I have the best job in the world. We've done 27 events this summer, well, summer and fall. We've had over 150 participants on those rides, and we have a wonderful experience. I have to tell you about this horse right here. This is JW. JW is my horse. He's my personal horse that I take out on these events, and they love him. And he loves them. He thinks he's a person. He doesn't know that he's a horse. And he is very interactive with these individuals. Picture, you saw him earlier with a veteran with his arms wrapped around that horse. And that veteran, he loves him. And he's actually attributed a lot of good things in his life to that horse. One of them is his marriage. First ride he came on with us one year, he brought a girl with him and he kissed her for the first time on that ride. Second ride he got engaged. Third ride he called me and he said, we're going to be 20 minutes late. I said, okay, we'll wait for you. They had gone to the judge and got married. Just on a whim. I told him we're done, we're not going to the next step for that year. But we have a lot of good opportunities. We've been all over the state, and we have a lot of important things. We've got a lot of new developing programs. Just this fall, I've implemented a program with veterans where I'm teaching them to drive horses. Olaf and Sven are really good, and we are having a lot of fun with that program. But we're very grateful for that relationship with the Salt Lake City VA and for the opportunities. When you talk about joy and horses bringing me joy, this is what brings me joy. When I can share with my family and my kids. I've got 9 kids. So yes, the previous hour scared the daylights out of me when he talked about what's out there. And it scared me to death. So this is what brings me joy. Horses bring me joy, and my family brings me joy. So anyway, thank you for the opportunity, and we do have some time for questions. So if you guys have a few minutes, how much, 2 or 3 minutes? We do have some time for questions. And we can call on McKenna as well. She's actually going to be part of the presentation this afternoon, or this evening out at the fairgrounds. Yes?
What are you going to be demonstrating out at the fairgrounds?
It's going to, well, McKenna, what are you going to be demonstrating with Heather?
So, I'll stand up. Good thing I have an instructor voice I can now.
Yeah.
We're going to be doing equine-assisted learning. So we have 2 miniature horses that are there. They arrived this afternoon when Karl came down. And it's going to be a teamwork activity. We're going to call some volunteers down, and you will be given personas that you need to act out. To kind of give you an example of what me and Heather worked on for how many sessions, I don't even know. A lot of different varying personalities and ages and diagnoses, and you'll have the opportunity to kind of step into our participants' shoes and see what it feels like to go through a session with an equine specialist and a mental health professional.
Thank you. Yes?
For this program, do you do rescue horses, or what do you?
As she mentioned before, a lot of our horses are rescue horses. Just like with each of us, we need rescued. But many of them are specifically not necessarily rescue horses. Olaf and Sven that we talked about, Sven is the one that has the scar on the side, and there was an injury earlier in his life where somebody tied him to a trailer and forgot he was tied there as they drove off. It was terrible, but he has been able to come back and to trust people. And he is a wonderful horse, and we love him. So there are many that we would consider rescue horses, yes.
Because my daughter does rescues horses in West Virginia and trains them.
Yep.
For this kind of program.
It works very well, but you've got to make sure that they're ready for the program before you bring them in. Yes?
Can you get paid for this? Like, are you?
It is a great question. That is one of the problems that we have, is that insurance companies don't always pay everything that's going on. You've got to pay the equine specialist and stuff. Mental health professionals can bill it out when they are the mental health professionals providing that's whatever you call it, a therapy or a interaction. But it's hard to often charge for how much the horse is worth. And the upkeep and stuff like that. That is one of the barriers that we experience in that industry.
I'm gonna pull you this way so you don't fall off.
Oh.
Back up.
I will say this, that's one of the motivators behind the reason why we're doing research and collecting data is because if we can continue to demonstrate that it's an evidence-based intervention, then it becomes easier to integrate into other programs that are already established. So I don't bill out per hour because I'm part of the VA, right? And so we're trying to use this to pilot and now support other VAs around the country that want to do the same thing. So it's not a yes or no, it's complicated, you have to get creative, but the more evidence that we can demonstrate, the stronger of a position we are to make it a broader based intervention.
So far, we've published 4 and almost 5 papers with these studies. And I bring that up because there has been 0 papers published in the past. So this is really good pioneering work, and we're excited about it. So thank you.
I'll grab it for you.
All right, so I want to point out again, this thing has been giving all of us problems all day.